At ASCO 2024, I asked 5 in-depth questions to Abhay Singh from the Cleveland Clinic on therapy-related myeloid neoplasm risk score, TMNRS. If you don't like the first one, there's 4 more in the description below. Make sure to watch to the end because the last one is the best.
The purpose of this study was that there have been recent risk factors that have been reported, not recent, probably over the last decade or so, there's some ambiguity existed. So this being prior history of autoimmune diseases, the role of growth factor, granulocyte colony stimulating factor that's pretty widely used in the care of our cancer patients. But there was always this ambiguity between the studies, whether they were harmful or they were leading to, they had any contribution to TMN. So in our study, when we were developing the TMN risk score, we looked at about close to 1 million patients, and then we included cancers where we had data on TMN development in at least 150 TMN cases for each cancer type. And we identified across the board through all cancers that we studied that novel predictors of TMN were prior history of autoimmune diseases that remained consistent throughout all cancers in our training cohort as well as in our validation cohort as well, and prior exposure of granulocyte colony stimulating factor, or commonly referred to as growth factor. So I think these are the 2 novel things that came out in the risk score studying a large population of patients. So we used a large population database. It combines SEER, which is a registry database for cancer patients, and then the Medicare claims database, which includes Medicare patients age 65 and above. And the reason for using this combined database was that there's some medical or complex medical information that is not available in SEER that we were able to extract, like chemotherapy exposure, kind of chemotherapy exposure, radiation exposure, history of autoimmune diseases that might require chronic immunosuppression, or autoimmune disease that might require just pulse dose steroids and then no more immunosuppression. So I think that was important for our study, that we had that granularity of data, and each type of autoimmune disease we had data to kind of very granular details. And then this was a combined database, so we had a very granular information. We were able to put in risk factors into the risk score that were identified through the univariate analysis at first, and then there were significant associations seen, and then what was significant was taken into the next step, and then we forced some of the risk factors into the model. There's this entity called clonal hematopoiesis of indeterminate potential, which is a precursor state to myeloid neoplasms and has been shown to be associated with autoimmunity, has been associated to be associated with cardiovascular disease and other outcomes of interest. So those risk factors were forced into the model. And then the risk score itself was a very simple arithmetic sum of the weighted adjusted odds ratio identified for the logistic regression analysis. So that's how we were able to develop the TMNRS. Through this score, what we were able to do was that we were able to define absolute risk. This is different than relative risk. So because with the absolute risk, we know that there's a 1% chance, 2% chance of developing myeloid neoplasm through one's lifetime once they enter the period of survivorship. I think that's a huge development in the field, because we've so far lacked absolute risk, a study that could tell us the absolute risk. We've had knowledge about relative risk, but that's less pragmatic or practical. So I can think of a scenario where we commonly, for our breast cancer patients, they get, for early stage breast cancer, they get a lumpectomy done, and then they have a tumor tested for a genomic test called Oncotype DX, and based on that, the predict calculator is there that'll give how the survival may change if they get chemotherapy or not, right? And often you can see with adjuvant chemotherapy that survival benefit may be 1% or something along those lines. In those situations, if we plug in the numbers in our TMNRS and we find that the risk of myeloid neoplasm down the line is 1.8%, then that may be a situation where you might want to forego chemotherapy because that patient's at a heightened risk of myeloid neoplasm down the line. Similarly, if the TMN risk score is high, that might be a situation where you might want to forego granulocyte colony stimulating factor. If that can be avoided, I think that should be the strategy. Another thing that this TMNRS may inform is that we are well into the era of precision oncology, and these precision-based tests or the next generation sequencing tests cannot be applied widely to all the population because of the cost, because of the anxiety that can happen with the results of these tests. So this TMNRS may inform us where that NGS-based testing from the blood might be more informative, and then that can be a viable screening strategy to identify patients who may be at risk of developing myeloid neoplasm, let's say 5-7 years down the line. The c-statistic score ranges anywhere from 62 to 70% in our study, around that range, which in my mind is a great first step because nothing like this exists so far. For the next steps, we're planning to query larger databases that are better annotated. So there are many databases that are available out there that we'll try to leverage and then improve the c-statistics. If at some point of time we have molecular data available as well, there are large cohorts that are out there where we can get molecular information or clonal hematopoiesis information as well. So that may be a strategy to include that molecular information into the TMNRS and perhaps make a CH-TMNRS score, and that will increase the c-statistics for this model. The online calculator or the web-based calculator is being developed currently, and it will be a simple risk calculator where a treating oncologist in the office can plug in the clinical factors. If they're planning to give chemotherapy, if they're planning to give GCSF, if the patient has prior history of autoimmune disease, if the patient has a radiation exposure that might be planned. So after plugging all those numbers in, the web calculator will give the absolute risk that might be there for patient to develop myeloid neoplasm. And if that risk is high, that will be a strategy to think about risk mitigation strategies. Would you really want to do chemotherapy in that patient if the cancer is out and the benefit is only marginal? Would you want to do GCSF in that patient? So I think for a treating oncologist, and I've had conversations with many of our community oncologist colleagues as well, and they're very excited about this model because they go through this on a daily basis where they're trying to make that call, should I or should I not? So I think having that web-based calculator is going to be help our treating oncologists and to the benefit of our patients, wherein we can actually predict the risk and then do risk mitigation strategies and improve the outcomes of our patients.